Great to have you with us. Helen Farmer here. You are listening to Eye on Health on Dubai Eye 103.8, brought to you by MedLab Middle East and Arab Health. And today we're delving into a topic that has largely remained a bit of a mystery to many, many men, a lot of women and also doctors around the world. Yet every woman will experience it eventually. What are we talking about? It's the menopause, of course. And who better to chat about this than Dr Fiona Rennie, a.k.a. the Menopause Doc from Genesis Clinic. You are the go-to in the UAE when it comes to, obviously there's appointments, but also no-nonsense discussions, advice, your hot take on some of the headlines, the myths and misconceptions. And I wanted to ask you, first of all, why you're so passionate about this topic and educating the population about it.
Well, number one is I've been through it myself, so I know how miserable it can be. And when I went through it, there was absolutely no help at all. Secondly, I see a lot of women not getting the help they need. And it is so easy to treat. It's so easy to help people and make people feel better, improve their quality of life.
I feel like conversations have really exploded, certainly out of the UK recently on this, and it's taken people in the public eye to speak up and say, this is what I've been experiencing, this has been awful, or to say, do you know what, I'm thinking about this being a new chapter of, renewal and actually the start of something rather than the end of my, fertility, my desirability that often fetishizes youth. But as I said, there's still an awful lot of misinformation and confusion, I guess, around the menopause. So we're going to be doing our bit today to kind of clear that up, and also the perimenopause too. So I know this is very much your bread and butter and conversations you have every day, but I think we need to assume that there's perhaps a lack of information and baseline knowledge out there. So can we talk about some definitions, some terms?
Okay, so perimenopause is the period of time leading up to menopause. The definition of menopause is no menstrual period for 1 year, and that usually occurs around about 50, 51. The time before that, which can be 10 to 12 years, is often forgotten about. And every day I get women telling me that their doctor has told them that there's nothing wrong with them. They're fine, they're still getting their cycle, there's nothing wrong with them, and they're too early to be in menopause. But that's not the case. So perimenopause can start mid to late 30s, typically more around 40. And what happens is that your hormone levels are dropping. So you're still ovulating, you're still having your cycle, but when you do ovulate, you don't mount a good hormone response. So you're not making enough estrogen and enough progesterone. When your estrogen drops, several things happen. One is that you become insulin resistant, and that's often why people start to struggle with their weight in their 40s.
Middle-age spread,
exactly.
The tummy area.
Exactly, and that's when you have to start looking at what you're eating, how you're exercising. Secondly, estrogen is needed for every single cell in the body to function normally. So these women will often tell me that they're feeling more overwhelmed by things. They feel they've developed anxiety when they've never had it before. They're not sleeping well. They'll get off to sleep and then wake in the night and their sleep quality is poor. Then they can't get back to sleep. Irritable, emotional, memory, concentration, feeling really flat, lack of motivation, feeling tired, and then joint aches. So they'll be going to see doctors about injuries that are not getting better, about sore knees, sore hips, and often it's all hormonal. So it's misunderstood by a lot of medical professionals. They haven't been taught the physiology behind it, but also it's not their area of specialty. So I really feel for the woman between 40 and 50, because after 50, it's a bit of a no-brainer. Your periods stop, you start getting flushes, you start feeling awful, and it's very obvious what it is. But so that's why I'm so interested in perimenopause.
Yeah, this kind of hinterland of confusion. And I mean, just some of the symptoms you mentioned there, it's like an Ottolenghi recipe list. There's just, so many potential ingredients
and that's
in
only
this.
half of them.
I can only imagine, because there are some really weird and wonderful ones out there. I want to come back to the mental health side, because we unfortunately see an awful lot of women who are misdiagnosed with anxiety, who are perhaps prescribed antidepressants when really we should be looking at those hormones. How do we check? If someone comes into clinic, unfortunately there doesn't seem to be a magic bullet blood test that can say you are in perimenopause. It is a case of finding a doctor who is well informed, who can start to put together, a bit like Dr House, those
bit of a
those
puzzle.
clues. Exactly.
And I'll often say to people, look, I don't know whether this is a depression and anxiety disorder or whether this is hormonal. Sometimes it's very obvious, but for people that have had depression and anxiety in the past, it can be quite hard to unpack it all. So sometimes I'll say, right, let's try some hormone treatment for 3 months and see what happens. I do have some women that don't respond fully to hormones, and if they do have the mental health symptoms, they might need a very small dose of an antidepressant as well. But I think it comes down to listening, taking a careful history, asking them what's going on in their life. And once you start, you can go down a rabbit hole at that point. But I think what I've observed is that 30, 40 years ago, women got married young. They had their children in their early 20s. They were gone by the time they hit 40. And then things were a lot easier. Now women are having children later. They're holding down a full-time job, especially here living as an expat. That can be stressful, financial problems, children at school. And some women have their children in their early 40s and go straight into perimenopause. So they're trying to manage no sleep because of the children, plus all the hormonal changes. So
it's a lot.
And things have changed over the years.
Yeah, massively, because, historically you maybe hit menopause, or certainly perimenopause, 40s into 50s, and the life expectancy wasn't that long. So you might only have a decade or so where you might be in pain or discomfort or distress. Now, we're living an awful lot longer, so we could ultimately be having 30, 40 years.
Correct, and that's something I often explain to people. 100 years ago, the average age of menopause was around 57 and the average life expectancy was 59. So there was just one phase to a woman's life. They tended to have babies much later, actually. And then, so that their fertility would span from sort of 18 to 45. Now, average age of menopause is 50. Average life expectancy is around 85 for a woman. So you can be 35 years without hormones. So it's not only about the symptoms, it's about what happens to your body when you're not making estrogen anymore.
Absolutely, that quality of life. So let's talk about some treatment options, Dr. Fiona, if you don't mind. And let's look at the UA in particular. Internationally, we have unfortunately seen quite drastic shortages, and I know that has been something of a factor here. So let's say someone comes to you and they are firmly into their mid to late 40s and they've got that, ingredient list of some of the things we've been talking about today. How do you then decide which route to take with them?
Well, we'll talk about lifestyle. You've got to get a few things right first.
Some foundation blocks.
Exactly. Hormones, giving people hormones don't fix everything. So first thing I talk about is exercise. So really important as you age to start strength training, weight training, resistance training. A lot of people will say, yes, I walk. Walking is not enough. Yoga on its own is not enough. It has to be a mixture of things.
And why?
Because from the age of 35, you start losing muscle. And it's a condition called sarcopenia. It's a loss of muscle. The muscle is replaced by fat. You may not look fat on the outside, but you'll have fat on the inside.
That visceral fat around
Exactly.
organs, which is more dangerous.
Exactly. And muscle is metabolically active. So muscle controls hormones. Muscle has insulin receptors, so helps with the insulin resistance. Muscle keeps you flexible. Muscle reduces your risk of cardiovascular disease, of diabetes, some cancers. So that's what we all should be doing.
And then there's the bone density piece as well.
Correct. Weight-bearing exercise, bone density, strength training. So what happens when your ovaries stop working and you stop making estrogen, testosterone and progesterone is that your bones will start to thin out. Your risk of cardiovascular disease increases rapidly. Your risk of diabetes, dementia, and now there's some evidence coming out that your risk of colon cancer may be increased. So we talk about hormones for symptoms, but we also talk about hormones for prevention. It really is, there's really, really very few disadvantages to being on some hormone therapy. And you can make a good case that all women who are menopausal should be on hormone replacement therapy because you spend so long without your hormones now. So, so first thing I talk about is exercise, then I talk about diet, and we really all have to up our protein.
Okay.
We should be getting at least 100 grams of protein a day, so 30 grams per meal, which is actually quite hard to get.
I know, I'm just doing some maths going, that's quite a lot.
That's a lot, and I really struggle with patients that are vegan and vegetarian. I respect their choices, but almost all alternatives to meat have high carbohydrate content. So there'll be some protein, but also a lot of carbs.
And also the processed aspect as well could be a bit tricky.
So your carbohydrate to protein should be 1-to-1. If you have 100 grams of protein, you should have no more than 100 grams of carbohydrate, because you are fighting against this whole insulin resistance. And the ways to build muscle, apart from lifting weights and strength training, is to eat enough protein so you can build muscle. So we talk about that. Sugar is inflammatory. So sugar is linked to autoimmune diseases, some cancers. There's more and more work being done on sugar and what it does in the body. So we talk about healthy eating, lots of protein, lots of vegetables, salads, cooked vegetables.
Those good whole foods.
Good whole foods, cutting out sugar as much as possible, and really reducing alcohol, because alcohol and menopause and perimenopause don't go well together. So they are the first two things I talk about. Then I talk about supplements. Everyone needs to be on vitamin D and keep their vitamin D levels up. Magnesium, and I will recommend magnesium glycinate, because that's really good for sleep and calming at night, and sleep is almost always disturbed in perimenopause. Omegas, and then just general multivitamins. And then we get on to the hormone treatment. So there's 3 different types of hormone replacement therapy. There's your old-fashioned, synthetic, oral, bit like the contraceptive pill but in a lower dose. I tend to avoid that and not prescribe that. And we use mostly the body identical hormones. So they are made from yam, so they're plant-based. They are yam molecularly and chemically is identical to your body's hormones. So you basically,
so strange.
I know. You're stabilizing those fluctuating estrogen levels with something that's identical. The risk is incredibly low. In fact, almost no risk of taking these hormones. And they also have an anti-inflammatory component.
What form do they take, Dr. Fiona? And I only ask because I've seen a lot of panicked posts on social media recently going, I'm running out of this gel.
Yeah, so there's 2 ways of using body identical estrogen. One is a patch and the other is gel. There's pros and cons to both. So we use the estrogen. Women that still have a uterus, so women that have had a hysterectomy only need the estrogen. Women that have a uterus need progesterone as well, and we use plant-based progesterone. The third product is testosterone. And testosterone is needed for energy, motivation, libido, memory. Not everyone needs testosterone, but that's also a gel, also yam-based. So there's those 3 products, and that's the basis of HRT. And in my opinion, all women that require HRT should be started on body identical in the first instance.
Can I ask you, as they
hormones?
I think and having heard interviews with women who've been in exactly that predicament, where their life, their mental health has been so difficult and so precarious that it's a risk they're willing to take. You know,
exactly, and it's their choice.
Absolutely.
So there's a lot of alternatives. If flushes are a problem, there is a new drug that has been now approved in the UK and the US, and we're currently trying to find out if it's coming to Dubai. So that's a non-hormonal treatment for flushes. Some of the antidepressants are really helpful for menopausal flushes. I talk to women about just the things we've talked about: lifestyle, sleep, getting good sleep. And with this, we have other ways to manage the symptoms non-hormonally.
Dr. Fiona, can I ask you, why might some women have a really, really rotten time of it? And why might some just completely sail through the menopause and go, oh, I'm late 50s actually, I haven't had a period in quite some time and I didn't really notice anything that happened. You know, and I'm not just necessarily talking about those, you know, those building blocks and those ideas of prevention. Is it completely by chance sometimes?
Yeah,
or
I have no idea. Absolutely no idea.
So we all need to keep our fingers crossed, really, if we haven't hit it yet.
Look, honestly, the more stress you have in your life, travelling, and it was a completely different scenario. But they suffered as well. And interestingly, my opinion, and I don't actually know if this has been studied, but the whole benzodiazepine addiction that happened in the 60s and 70s with Valium and women being given strong tranquilizers, I think that was menopause.
Oh, that's
because one
interesting.
of the commonest symptoms I see is anxiety.
Mm-hmm.
And I just think that was unrecognised menopause.
Can I ask you then, if perimenopause and menopause aren't managed properly, how bad can it get? And perhaps it maybe even leading to some chronic illnesses and issues that you've seen in clinic or heard of through studies?
Well, interestingly, I was listening to something recently and a woman was talking and she said she was on the verge of divorcing her husband and she went on HRT and she realised she actually quite liked him. And it was nothing. It was menopause symptoms.
I'm a bit like that with PMS. I plan a divorce almost monthly.
Patients will tell me that they can't bear to hear their husband breathing or chewing. So it can get pretty bad. It can get really bad. And if people aren't sleeping and they're full of anxiety, it's pretty disabling.
But then conversely, I'm just going to find the podcast I was listening to recently on this topic, which was with a author. And she looks, Dr. Sharon Blackie. She's written a book about leaning into what she calls your haggitude as you get older, like really loving being older. And what she said was when she hit menopause, she said it was like a veil fell from her eyes and that all of this hormonal muddlement that she'd been through over the years, she said she had absolute crystal clarity. Said, she felt so much more capable of making decisions because she wasn't being, overwhelmed by. Yeah. I think it's such an interesting way of looking at it.
Way past it, and I feel the fittest and healthiest I've ever been in my whole life. And it's another phase of your life.
That's exactly what I wanted to end with when it comes to this sense of attitude, mindset when it comes to it. I mean, rather than it being this defeatist, oh gosh, well I'm going to get a big tummy and, this is just, no one's going to fancy me anymore. This idea of empowerment and exactly that, turning a page on a new chapter. How much do you think mindset can play a role? And I'm certainly not saying think positive every day to overcome, these enormous hormonal changes, but it must be significant.
Yeah, it is empowering. And I work hard at it.
It's a choice.
I work hard. It's a choice. I make sure, the most important thing with sleep is to go to bed at the same time every night and go to bed to get up at the same time every morning. And I've become a bit of a social recluse because of that. Because you just work on it's a fine line.
Yeah. And you're wearing your Whoop now. So for anyone that isn't familiar, we're talking about wearables, which has come up an awful lot actually on iron health in various aspects when it comes to precision medicine and preventative care. How important do you think it is to know our data when it comes to sleep and heart rate variability? Is it something you advise women coming into the clinic that they tune into, or can ignorance be bliss sometimes?
I like it, but I have had to tell people to stop wearing their wearables because they get a little bit fixated if their heart rate changes over the day or their blood pressure goes up, and then they start to worry and get anxiety.
Data anxiety.
Yeah, I like it. I train. It helps me know when I should be resting, when I should have a day off, training. It helps. I guess it's, nice to know that you've had a good night's sleep or you haven't had a good night's sleep. And so I find it really useful. Dr.
Fiona Rennie, is there anything that we haven't touched on today that you'd really like to get across to people listening today regarding the menopause?
I think if you go and seek help and you don't get the answer, a satisfactory answer, you just keep looking. Also, to educate yourself. So you go and see a doctor knowing what you want and knowing a bit more about your condition, because they may not recognise that it's a hormonal issue.
Thank you.
By 103.8.
Join the conversation.